Welcome to this short video that highlights responsive behaviours associated with dementia. By the end of this presentation, you will be able to assess and understand these behaviours and offer a range of management options. The video will lead us through the role the practice team can play with those exhibiting the responsive behaviours. To help us better understand assessment and management of responsive behaviours in dementia, we will follow the story of Jack, his son and daughter, and carers. Jack is a 78-year-old former farmer. He has had dementia for 8 years, and he was recently admitted to full-time care in a residential aged care facility. Since moving from his family home, he has started exhibiting behaviours which are out of character for Jack. He has been wandering the halls of his aged care facility late at night in an agitated state. Over the course of the disease, some 90% of people with dementia will show symptoms of what used to be called BPSD, behavioural and psychological symptoms of dementia, and now termed responsive behaviours. These responsive behaviours can include aggression, screaming, restlessness, repetitive questioning, shadowing, and wandering. Other behaviours can include hoarding, ruminating, sexual disinhibition, apathy, and withdrawal. Depression, anxiety, and psychotic symptoms such as hallucinations and delusions can also be evident. While responsive behaviours can occur at any time during the course of a dementia, they are more likely to be seen as the disease progresses. During the terminal phase, where significant physical decline often occurs, there may be a reduction in responsive behaviours. So how should responsive behaviours be managed? Firstly, reversible causes of the behaviours must be identified and treated. These could be delirium, infection, pain, constipation, hunger, and thirst. If potentially reversible causes are identified, they should be treated and the behaviour reassessed. If no reversible cause is found, further investigation of the reason for the behaviour is needed. Staff in a residential care facility or a primary healthcare nurse, if the person lives at home, can be asked to conduct a comprehensive assessment of the behaviour, looking for possible causes and triggers in the person's personal story, medical condition, and past history. This should be done in consultation with the person's family. A good way to gather this information is to use a structured approach such as the CAUSED model. CAUSED guides nurses and care workers to ask questions which might identify the reason for the behaviour or what the person may be responding to. Once a reason or trigger for the behaviour is identified, interventions can be put in place to minimise the risk of the behaviour reoccurring. A detailed behaviour description chart is useful to identify patterns and triggers. Does the behaviour occur at a particular time of day or with certain people? The description chart also assists in determining how effective the chosen intervention has been. The caused model includes recording of date and time, an accurate description of the behaviour, a detailed description of any attempted intervention used, and its outcome. This assessment should be regularly reviewed, looking for patterns and causes. Pharmacological intervention for responsive behaviours should only be considered under the following circumstances: if pain is the likely cause, if the person, family, or carer are distressed, or if there is imminent risk of harm to the person with dementia or others. If the assessment indicates that pain may be the cause for the responsive behaviours, appropriate pain relief measures should be introduced. Pharmacological management should complement, not replace, non-pharmacological approaches. In cases of agitation, if a pharmacological approach is necessary, selective serotonin reuptake inhibitors could be offered on a trial basis. Currently, the best evidence for people with dementia displaying agitation is for citalopram. The effectiveness of the trial should be reviewed within 2 months. And if there has not been significant improvement, deprescribing in a gradual manner could be considered. The risks of withdrawal and other side effects should be made clear to the patient, family, or carer from the outset. If people with dementia show distressing behavioural or psychological symptoms, it may be necessary to use antipsychotic medication. The risks and benefits of antipsychotic treatment need to be explained in detail to the person with dementia, their carers, and family. Antipsychotic medications increase the risk of stroke and may cause further deterioration in cognition. Comorbid conditions such as depression, delirium, and pain also need to be considered. Risperidone shows the strongest evidence for treating psychosis in people with dementia, while risperidone or olanzapine may be used for agitation or aggression. People with Lewy body dementia may have particularly severe adverse extrapyramidal effects from antipsychotics, with double or triple the mortality rate, and such treatment should be avoided if possible. It has been discovered through a detailed behavioural assessment that Jack, being a farmer, would check all the farm gates at the end of each day. It was thought that this may be the reason for his agitated wandering at night in the residential aged care facility. Jack's carers and family supported recommendations from the responsive behaviour assessment. The nursing staff agreed to take Jack with them while they did their evening medication round. Jack responded well to this approach, becoming less agitated in the evenings. It was agreed that the care team would regularly review Jack's progress with Jack and his family. A review has been scheduled for 2 months. A structured approach to the assessment and management of responsive behaviours in dementia allows nursing staff, carers, and family members to provide best possible care for the person with dementia, with consequent reduction in distress for all involved. For support and further information, please contact Dementia Support Australia, who supports staff and carers in community, residential, acute, and primary care settings with information, advice, assessment, and short-term case management interventions for responsive behaviours in dementia. This includes a 24-hour helpline. Your local aged person's mental health service can also offer assistance. Further training resources are available at Dementia Training Australia.